So hi everyone, my name is Matt. I'm a final year trainee in the BRI, and I've been asked to present specifically on the papers, scientific papers that you'd use for the FRCS. I've got a photo of Glasgow there, which is where I did my exam, specifically so I can tell you exactly what took place. I was in this hotel room, the exam took place there, and the final day was just as sunny as this, and the nicest, tastiest beer I've ever had was just there after the exam finished. So you've got all that to look forward to. Great, so what's the plan for this? Well, I'm not an academic trainee, so I'm not a scientific paper expert, but I can at least give you an idea of what it looks like to do the FRCS. And so I'm going to describe what the FRCS entails. It's impossible to talk about this without saying what the FRCS is and how the exam works. But I will take a slightly more detailed look at some upper GI papers. I'm wary that most people will not be upper GI trainees and either general, colorectal, breast, that kind of thing. But you do need to understand some of the fundamentals of upper GI surgery and some papers for your general surgery section. But we'll come to that in more detail. It will be a bit of a helicopter ride around those papers though. And then I will list some papers that the upper GI trainees we'll need to know more about. So the FRCS comes in two parts. You're only allowed to do it once you've completed an outcome 1 in your ST6 ARCP. And it comes in two parts. The first part is multiple choice. It's now 2 assessments done on the same day, normally in a driving test centre, to give you an idea of what you're up against. There's normally someone failing their driving test has a perception on your right for the 5th time and going in and out doing it while you're sat there doing the most important exam of your life for 2 hours and 15 minutes at a time. There's a break between the two, and each one has 120 questions. So that's a lot of questions to get through in that time. It's a single best answer format with 5 multiple choice options for each question, and the stems are quite long. We'll have a look at some questions in a moment. And there's 5 options, as I say, for each question. And then this I've literally just screenshotted from the JCIE website, which is a examiner's guide to writing these questions, which I think is a really important thing to know about, is what are they testing and why are they testing it? So as you can see from what I've highlighted, the questions that they're asking are not simple recall questions. The whole point of this exam is you can't go home and Google the answers the next day. They're not simple anatomy questions, and for the most part, they're not Googleable answers. Occasionally there are questions like that. But what instead they're asking you to do is to take 2 steps of knowledge with every question that they ask. So you'll be given a vignette for a patient. It'll be an emergency event or a situation in the clinic with a history and some investigations. And then a typical question is, what is the most appropriate first step in the management of this patient? So that's the kind of stuff that we're being asked. And we'll come to a few of what the questions look like in more detail in a moment. But before that, I'll just share a few very quick tips for part 1, which I wish I was told at this stage. So firstly is familiarise yourself with the syllabus. The syllabus has some surprises in. You think that it's just going to be examined on the stuff, your bread and butter every day. And for the most part, it is that. And you will rely an awful lot on the intuition and initiative that you've learned in your multiple hours on call as a general surgical registrar and in clinic, etc. But there are some parts of the exam that are easily testable, but not necessarily stuff that we do day to day in clinical practice. Stuff like skin lesions, stuff like vascular, stuff like upper GI bleeding, because that almost always goes to the medics for the most part. And we do need to learn those things in depth. So have a look at the syllabus before you start learning anything. Number 2, if I was to summarize, if I was to say one thing that's the best thing to read, to revise, if you're only going to read one thing, then it would be to read guidelines. And I'd say that's even far and above doing practice questions on question banks online. So of course everyone uses question banks, but a lot of those questions, I thought if I'd have read the guideline on that, then I'd have got that right. Or in the example of GISTs, for example, there are about 5 questions on GISTs in my exam, and all of them, because I read the guideline the day before, were straightforward. And the reason they ask questions that are easily answerable if you know the guidelines is they're not contentious, right? If someone's issued a guideline on something, it's not an area that we in surgery are wondering if we've got best practice in. It's not debatable, it's just the answer. And I've mentioned colonoscopy intervals for polyps, for example, because just to remind me to say that they do look at up-to-date guidelines as well. So a colleague and I learned all of what we thought was the up-to-date colonoscopy guidelines, intervals for polyps, and committed that to memory, and then realised that a year previous, in 2020, they released a new guideline, which was totally different. So do bear that in mind. And then finally, use your intuition, and you'll see in the questions in a moment what I mean by that. And because we're talking about papers for the FRCS, I want to hammer home, you don't need for the part one to have an in-depth knowledge of the latest scientific evidence, but you do need to have a basic understanding of where our practice came from. So have a look at these. Hopefully you can read them in the room. Should be easy to read at home. But have a look at these two questions. I'll give you 2 minutes, because that's how long it will take you to do these questions in the exam. And I won't ask you to shout out what you think the answer is, but have a think about what the answer is, and then we'll talk about what it could be. So that's 1 minute so far. Okay, so that's 2 minutes. So before we talk about the answers, I put these up because these are example questions from the website. What I don't have is the answers. They don't give you the answers. They give you 5 example questions for general surgery. So this is exactly the sort of questions that come up. That top question I've seen come up a lot. This is being recorded, so I won't say more than that. So I won't ask you to say what you thought the answers were, but I think the answers to these 2 questions are E and then A. And the reason I wanted to pick these 2 questions specifically is they are relatively straightforward. There's nothing too frightening about them until you start reading some of the answers and think, oh, that sounds interesting. This guy's got dilatation on his abdominal X-ray. Maybe if we do a colonoscopic decompression, that will get him out of trouble. No, a good colorectal surgeon would tell you that there's one operation for acute refractory colitis, and that is a subtotal colectomy and endodostomy. And they have to put 5 different answers, and some of those will attract you, but just back your initiative and your intuition. And if you've seen something done before a lot, if 80% of the time in your practice, this person you've seen would have a subtotal colectomy and endodostomy, that's probably the answer. And then the second question here, I think, is testing our ability as consultants, because the whole point is the day 1 consultant exam, to make the difficult decisions if we need to, right? And for me, I look at this question, I don't think B, C, D, or E really offer much for this patient. You look at them, yes, they're young, they're in their 50s, but actually there's a lot of very, very bad prognostic signs there, and this person probably won't survive. Now, in my exam, I remember a series of questions where there were loads of options, for example, to do interventional radiology procedures on bleeding spleens, but on every single one, I thought, actually, this patient's, up the creek without paddle. I think we should do a splenectomy. And for, I passed the exam, so hopefully they're all right. But I think I took out about 4 spleens in that exam. And I think that's not just because I like taking out spleens. but I think that's because they're testing our higher order thinking and to make those difficult decisions sometimes rather than back out and make it someone else's problem and just tide it over. Right, that's all I wanted to say about that. Now we come to the part 2, which is probably a bit more relevant for this talk. And so part 2 has 2 parts. There's a clinical part and an oral part. Both are weighted equally, 50%. The clinical is a half day, the oral is a full day. In the clinical section, and I must point out, if any of you are doing the exam before August, this isn't relevant. There's no patients before August. I didn't have patients in my exam because of COVID. After August, this is what the guidelines are from the JCIE website. So clinical is split into half general surgery, half your subspecialist interest. There are 2 10-minute clinical scenarios for each with no patients and 1 long case scenario with a patient. I think they've taken the patients out of the short case scenarios because to do 10 minutes with a patient is quite challenging. And I think they struggle with that. So that's the clinical part. The oral part is 4 30-minute stations as described there. As you can see, there are 2 that would fall into the category of general surgery and 2 that fall into the category of special interest surgery. And what I've written at the bottom there is on the JCIE website for all of those sections, with the exception of section 2, there is a line which says all with discussion of published evidence supporting clinical practice. Now that's quite an intimidating line because you think, gosh, I need to know all of these publications off by heart in order to pass this exam. That's not the case, and I'll come to that in a minute. So what are your expectations for the exam? This, again, from the JCIE website. What I haven't put there is your subspecialty. On the subspecialty section, it says that you need to be at the level of a day 1 consultant in your subspecialty. If you're doing upper GI, that means HPB as well. I think that's set to change, but I'm not sure. And then vice versa. If you're doing HPB, it means upper GI as well. But if you are, say, a colorectal trainee, then for both section 1 and section 2, you only need to know transplant, breast, endocrine and vascular to ST4, but you do need to know them. You're not giving up on vascular and breast if you're a colorectal trainee. You do need to know them to the level of ST4, and that's what's expected of you. But elective and emergency general surgery at ST8 level. So this is a busy slide. Hopefully you can see some of it, but the only thing I really wanted to draw attention to is what I've highlighted there. So again, from the website, this is the marking scheme, which is readily available for everyone. For reasons known only to them, they score us for each question out of 8, and the lowest mark of that was 4. I don't understand why. A fail on that question is a 4 or a 5, as you can see in red, and a pass is a 6, 7, or an 8. Now, from what I understand, 8s are given out extremely rarely. An examiner might give out 1 or 2 8s a day when they're examining. So 6s and 7s are what we're really, for the most part, aiming for, unless you're a really high flyer gold medal winner. Now, what you'll notice is I haven't highlighted any part of 6, and that's because published evidence is not mentioned at all in the pass mark of 6 points for each point. Okay, so you can pass this exam without mentioning a single published paper. If you are talking about published papers, then you're probably looking at a 7 or maybe even an 8. And in 7, it says, provided supporting evidence and familiar with literature. And in 8, it says quoted from literature. So those are their words when it comes to scientific papers in the FRCS. Just in preparation for this, I just canvassed 5 other colleagues and myself about mentioning specific scientific papers in their exam. In the general surgery section, which is generally recognised as the easier part, 3 volunteered papers, they just told them then out of the blue, and none of them were asked. And in the subspecialty area, 4 volunteered and 2 were asked. So all 6 of us talked about papers in some form in our exam, but all of that was in the subspecialty section for the most part. What I must also say is almost all of us were asked additional questions on the papers that you mentioned. So if you bring up a scientific paper in your exam to illustrate that you know a lot about this topic, then be prepared to answer some questions back about it. Okay, so which study group published that? When was it published? Is it still relevant today? Do you have any critiques on it? That kind of thing. So my tips for part 2, again, just to make 3 tips to make it easier and move on to some papers. Remember, this is a day 1 consultant assessment. And Simon Dwerrihouse in Gloucester always used to say to me again and again, it's what you do every day. I think probably what I'd adjust for that quote is I'd say it's what they do every day, they as consultants. And if you think about when you did an interview to get into higher surgical training, if you're entering that interview as a core surgical trainee, the whole point is you're supposed to imagine yourself as a day one registrar, right? And talk as if you are one. And that's exactly what you're doing for the FRCS at a different level. And so we've all done it before. But what I mean by that is actually, if you look at the timetable for us versus the consultants, we're in theatre most of the week. They're doing MDT clinics, they're answering letters about strange pathology. And you need to think about what they do every day, not necessarily what we do. And so MDTs are your friend very much for learning this. Benign clinics, especially in upper GI surgery, are extremely helpful. I'm sure it's the case in colorectal as well, pelvic floor, that kind of thing. As I say, the main challenge is your subspecialty, not necessarily the general surgery section. I think that's an exception for breast trainees who, for the most part, turn up to the exam pretty qualified at breast. They've done a lot of years of breast and they've had a good immersive experience in their MDTs and clinics. So quite often breast trainees are anxious about the general surgery section. That's perfectly reasonable. But for everyone else, for the most part, general surgery is pretty straightforward, whereas the subspecialty is where people fall out or even fail. Then number 3, focus on learning a handful of important papers very well. So I am going to take you a bit of a helicopter ride of papers at the moment. We're not going to go too in depth to some things, but I would have committed to memory in order to say verbatim that the publication things came out in the year, and be prepared to answer some important questions about the relevance to your field rather than just saying what the paper was. One thing to say before I move on, when it comes to pass rates, we were discussing this just before. For FRCS Part 1, the pass rate in this DINA is something between 50 and 60%. So that's the one that people fail on. And I think it's probably because it just sort of turns up at ST7 and we don't necessarily prepare for it readily. Also, the multiple choice system makes it hard. Because you have to do a bit of exam prep in the way that you learn how to answer questions. Part 2 is the one that we all, for the most part, pass. There's, I think, a 90 to 95% pass rate for in-deanery trainees. So bear that in mind. Just as a kind of an example, one of my stations for the Part 1 exam was on small bowel obstruction, Part 2 exam, about small bowel obstruction from the femoral hernia. Now, that's our bread and butter, right? And that's something that I practiced a couple of times. It's a common station, totally reasonably, because it's a common occurrence. And I got a 10-minute viva on it, femoral hernia causing small bowel obstruction. And I had prepared some statistics in my head from the small bowel obstruction national audit, which I was going to be able to quote to them, because I knew then I can really show off and get to the 7s and 8s for this. I got nowhere near that in quoting those, because they were far more interested in that 10-minute station in finding out that I was a safe consultant surgeon who was going to be able to prepare that patient for theatre, look after them afterwards, perioperatively do a safe job, understand the anatomy of the procedure. And they didn't really care about whether I knew that some niche hospital in Manchester had great outcomes in their small bowel obstruction audit, because it's not relevant. It's not relevant for your day one consultant practice. So that gives you an example of what you can and can't say in the exam, given the time constraints. I'm just going to do a shameless plug for this book. I don't have shares in it, but I think it's great. It's old, but I found it fantastic in just giving me a historical journey through into our current practice, figuring out why we do what we do now. And unashamedly, I plagiarised a lot of what's written in that book for the rest of this presentation. So, now that I've told you a lot about how you don't need to know any papers for the FRCS, let's talk about some papers that you need to know for the FRCS. So, common themes for upper GI surgery in the general surgery section of the FRCS, so bits that everyone needs to know, are these. And the reason I put the top 4 in bold is those are the ones that we're going to go into in a bit more detail with the time that we've got. Okay. So we'll start with pancreatitis. So when it comes to learning about pancreatitis, it's our bread and butter as general surgeons. It's something that we need to know very well. And I would strongly, strongly recommend 2 papers for all of you to read, even tomorrow. And those are the acute pancreatitis summary from the Lancet 2020 and the Atlanta classification that was revised in 2012 from, I think it was previously done in the 90s and revised in 2012. Those are the main papers. The first paper is an excellent summary. It will tell you everything you need to know about pancreatitis in one paper. The second one explains a bit more about why, and we'll come to the second one now. So if you get a pancreatitis station and they ask you, for example, to define pancreatitis, then you can quote directly from the Atlanta classification. All right, so the diagnosis that we should all know requires two of clinical, radiological, biochemical. That's come from the Atlanta classification. That's where it's from. And I think the reason I put this in is to remind me to say that a lot of the stuff we do as registrars, we don't really know why we do it. The consultants do because they've done it for 25 years and their practice has changed as the evidence has come out. This is why the definition is there. It's the Atlanta consensus statement that brought it out. It's the same with grades of severity. And then one thing that we may not necessarily know, which I think is a really useful summary, is the morphological description of peripancreatic changes and fluid collections on imaging. And that's a very simple 4x4 table. It's either liquid or liquid and solid. It's either acute or more than 4 weeks. And then you describe it radiologically according to those findings. You may see that in some reports they don't use these words, and they should be. Okay, it's either an acute peripancreatic fluid collection or a pseudocyst if it's fluid. It's either an acute necrotic collection, ANC, or WON, walled-off necrosis, if it's got solid components. Okay, so we've talked about a summary paper. We've talked about a consensus statement. This is an example of a paper that was practice-changing, a randomized controlled trial that is useful to quote in your exam as to why we do what we do. Okay, so prior to 2010, it was established practice, as I understand, to do open necrosectomy for the majority of patients that are unwell with necrotizing pancreatitis. But the mortality rate was extremely high and the morbidity rate too. So this was an excellent paper done by the Dutch Pancreatitis Study Group, which I think is a knowledge of the papers that the Dutch Pancreatitis Study Group is essential for all trainees, and in-depth knowledge is not essential, but useful for upper GI trainees. It was published in the New England Journal of Medicine in 2010, and they looked specifically at a randomized controlled trial at step-up approach or open necrosectomy and necrotizing pancreatitis. 88 patients, 19 hospitals, and their step-up approach described either a percutaneous or endoscopically placed drain. Then after 72 hours, if there was no improvement, they do another drain. And then after 72 hours, if there was no improvement, a video-assisted debridement. And I think they then moved on to open necrosectomy if then there was no improvement. The other arm just went straight to open necrosectomy, and their primary outcome was mortality, but they were also interested in organ failure, systemic complications. And these were their results. Mortality, unchanged. Massive difference in organ failure, systemic complications, pancreatic fistula rates, etc., etc. VTE, obviously incisional hernia, through the roof in open necrosectomy compared to the step-up approach. And crucially, 1/3 of those patients who had step-up never needed anything more than just one percutaneous drain. So as I say, this is a practice-changing paper, one to learn, even for the general surgery section, and it altered the standards at the time. And the number of patients, if you were going to offer 1 point of critique, and I would get an understanding of these papers, but if you are going to learn things verbatim, offer 1 or 2 points that you can critique a paper, otherwise it just becomes too much. 1 point here is that the number of patients per institution was very low. If you remember, there were, I think, 88 patients, but 19 hospitals. So that's one thing to bear in mind. So it's difficult to standardize an approach when you've got such a small number of patients. Okay, I mentioned the Dutch Pancreatitis Study Group. This is 2 more big papers from the Dutch Pancreatitis Study Group. I would say that upper GI trainees need to know these, and other trainees do not. The Python study looked at early enteral nutrition, pre or post 72 hours. A lot of people come in with pancreatitis, don't feel like eating. Is it worth putting an NG tube in them straight away to try and feed them, offer good early nutrition? Turns out it makes no difference to outcomes for patients in terms of systemic complications, multi-organ failure, etc., and mortality. So that was a negative paper that's very helpful. And if you think about why our practice, for the most part on the wards, is to just see how patients do for the first 3 days, this is why. And then the tension study looked at endoscopic versus percutaneous drainage. 4 collections, and they found that essentially the outcomes were the same, with the exception of pancreatic fistula rates, which are much higher in the percutaneous drainage. So you'll notice that hospitals such as the BRI, which have access to endoscopic drainage readily, will always favour that. Plus, we don't have any IR there anyway. Oh, it's being recorded, isn't it? So next topic, gallstones. There's 3 main themes that come out from the exam when people are asked about gallstones in their general surgery stations. Bile duct injury, especially for upper GI surgeons, this is essential for upper GI surgeons, bile duct injury. Acute cholecystectomy and bile duct stones. I put the first 2 in bold because they're the only 2 we'll talk about. So, with pancreatitis, we've talked through the Dutch pancreatitis study group. We've talked through a consensus paper. We've talked about a summary paper that's useful to know. This is just, you don't necessarily need to read these papers, but this is just an idea of the history of why we do what we do, okay? Stephen Strasberg is front and centre for everything when it comes to gallbladder surgery, as many of you will know already. And that's because before this paper was published in 1995, they noticed that open cholecystectomy had much lower rates of bile duct injury than in laparoscopic. So they did a literature review, they generated the Strasberg classification, and that's where our critical view of safety that we all know about came from. He then went on to publish another paper in 2002, which is the first assessment, the first description, I should say, of risk factors of bile duct injury as well. Another paper we should all be familiar with came out in the Gurusamy et al. From 2010 in the British Journal of Surgery. It's now been updated with a Cochrane systematic review and meta-analysis in 2014, the same author. But it all started with this 2010 BGS paper. Then they were looking at early, as in less than 7 days, versus delayed, as in more than 6 weeks, acute cholecystectomy for patients with cholecystitis. They found 5 trials, and they were mainly looking at mortality, but also morbidity, especially bile leak and bile duct injury. And they found that essentially there was no difference between the 2 groups in the big parts of morbidity and mortality. You'll notice that there's a p-value of 0.05. Bile leak, they brushed over that, not sure why, in early. But when it comes to hospital stay, early is much better, working days lost, much better. I think you gain half a quality adjusted life here by having an early lap chole. That was all from this paper and an economic analysis they did in the same journal. And there's a 17.5% readmission rate while you're waiting for surgery if you go on the delayed pathway. So that's why we should all be doing early cholecystectomy, but we all know the troubles that we have in our various institutions with getting those through if we try to. Okay. So we've heard quite a bit about achalasia this morning, so I won't go into this in too much detail. But achalasia is a favourite topic of the examiners, even in the general surgery section, and I think it's just simply because it's highly testable, right? They can give you a nice picture of a barium swallow, like we would have had at medical school, the bird's beak appearance. They can talk about a young person with dysphagia, take a history from them, and then they can ask you a bit about achalasia. All right. Now, when it comes to achalasia, which is a failure, achalasia is actually Greek, it means failure to relax. That makes it quite easy to remember what it involves. Failure to relax of the lower esophageal sphincter, issues with contractility of the esophagus in general. And there are 3 different definitive treatment modalities. We can inject Botox into the lower esophageal sphincter, but it doesn't last. So there's dilatation, myotomy, or the alternative is POEM, which we heard about this morning in terms of what POEM involves. The 2 main papers that guided this are from the European achalasia trials, and they both managed to get huge numbers when you think about the rarity of this disease. They both had 200 patients in total, 100 in each arm in each paper. And the first, which is the one that we'll talk about, is dilatation versus surgical myotomy. And this is an especially useful paper when it comes to a critique, which will come in a moment. So this was New England Journal mentioned again, 2011, quite old, prospective multi-center randomized controlled trial. It was a Dutch centre, but done across lots of centres in Europe. 201 patients, 14 hospitals. And their primary outcome was an Eckhart score of less than or equal to 3. Achalasia the Eckhart score is a way of objectively scoring achalasia symptoms, and people who have a score of more than 3 are considered to have achalasia along, from a clinical context, alongside the investigation finding. They had a long follow-up period, and their year 2 findings were that there was no difference whatsoever in dilatation versus myotomy in terms of patient outcomes when it came to symptomatology. Quality of life was also unchanged, but if you consider relapse as a repeat dilatation required, then relapse is much higher in the dilatation section. Now, you look at this and you think, well, we'll just give all of our patients a quick GA, dilatation, no cuts, nothing. Why don't we do that for our patients with achalasia? And you heard a bit earlier in the fantastic talk this morning about why we don't do that. But in terms of a critique of this paper in particular, they had one critique is they had a high esophageal perforation rate when they performed a Heller's myotomy. 12% to me sounds pretty normal, but maybe that's just the ones I've seen. I've got a 0% rate from the one I've done, so that's fine. We'll keep it that way. 4 of the first 13 patients undergoing dilatation perforated, and those were excluded from the trial. Now, it's all there in the text. So if you're asked to critique that paper in your exam because you brought it up, then this is one thing to mention, is that the gastroenterologist perforated a whole bunch of patients first, and then they excluded them. And it's because the achalasia balloons that we use are much bigger than the ones we would use for simple benign strictural dilatations. And they were adjusting that for their protocol. But that's an unacceptably high number of perforations to start off a trial, really. Dilatation was repeated most commonly in patients younger than 40 years, which is now why we would say that a one-stop shop Heller's myotomy is the thing to do for young patients with achalasia, and that's more often when they present it, is that age group. Okay, coming to the end now. This is upper GI surgeon fodder. All right, we heard a lot about achalasia this morning, and what I would say is the Chicago classification is not something that you need to commit to memory as a colorectal breast transplant surgeon, but this is essential. This needs to be in your brain if you're a upper GI surgeon entering the exam, so that you can talk about this, especially in the basic science section where manometry and pH studies comes up a lot. We've got a talk coming up on OG cancer trials very shortly, so I won't go into, well, OG cancer in general very shortly, so I won't go into the trials in great detail. I'll just give the one slide summary that I wish I was given before I started learning about the OG cancer trials. There are lots, and they look either at gastric and junctional or esophageal and junctional tumours, okay? Most of them look at adenocarcinoma, especially obviously the gastric ones do. Most of them look at adenocarcinoma, some of them throw SCC and adenocarcinoma in together. The landmark trials that made neoadjuvant chemotherapy or neoadjuvant chemoradiotherapy the norm for patients with esophageal and gastric cancer are there: MAGIC, OEO2, and CROSS. Before then, we didn't offer patients neoadjuvant chemotherapy, and their outcomes were poor, but we were very anxious to offer them neoadjuvant chemotherapy because of how big an esophagectomy is as an operation, or a gastrectomy. And we certainly weren't interested in giving them adjuvant, given how long a recovery period it was, and how high a complication rate we have for esophagectomy, sadly. The ones that have updated since then, STO3 and OEO5 were negative trials when they added adjuncts in, and FLOT in 2019 is now the chemotherapy regimen of choice, especially for gastric and junctional cancers, adenocarcinoma, I should say, not for SCC. And that's been found to have superior outcomes in junctional tumours, but is poorly tolerated. 50% of patients don't complete their FLOT treatment. So that's why sometimes we revert back to the old style chemotherapy regimens, ECF, CROSS, that kind of thing. Right. If you were to learn 2 trials as an upper GI or a general surgeon for the exam, it would be CROSS and FLOT, because that's what we see in practice the most. There's a current, we're waiting for the results, or we do sort of have the results of the NEO-AUGUS trial. We wouldn't panic too much about that unless your exam's in 2 or 3 years' time. Any questions? Or from anyone online?
What courses did you do?
What
courses did you
I did, so the general thing to say about courses is they are not essential to pass. So not everyone does a course, probably about half people do a course. I did one super intense weekend course, which is called the Phoenix, because it was cheap and it was online, it was COVID times. It was just Viva practice, there wasn't any teaching. Some of the courses seem to try and teach you the entirety of the general surgery syllabus in 1 week and do Viva. And I think that's quite exhausting, especially when you're revising at the same time. So I just picked a course that did lots of Viva practice on the Phoenix. It was okay. They gave some bad advice as well as some good advice. Their bad advice that they gave, I think, is that they suggested that we should all talk extremely quickly to try and get to our grade 8 out of 8 points so that we can start talking about the literature. You need to talk quickly through the first bit. I do think that's the case. I don't think examiners want you to have a motor mouth. I think they want to be able to hear what you're saying and talk slowly and confidently. Anything else? How do I find out if they're asking questions online?
Isn't it like it's leaking?